My name is Nathaniel, and I'm a medical physics PhD student. And I'm going to attempt to summarize 3 years of work as part of my PhD in 20 minutes. So bear with me as I try and accelerate through this. So the PhD roughly falls into three areas: data analysis from the FET-PET and glioblastoma trial, in particular the nuclear medicine physician credentialing, as well as the radiation oncology credentialing programs. And then we'll move into FET-PET automatic segmentation, where I've conducted an external validation of a neural network that was developed in a center in Jülich, Germany. Then finally, we'll move into understanding how to best develop a robust radiomics methodology, particularly when we have medical imaging data that is pretty common, and that's by doing a meta-analysis of what we call the radiomics quality score, which I'll go through a little bit later. And then this meta-analysis was used to inform guidelines, which I'll try and touch on as much as I can towards the end of this talk. So a bit of background of FET-PET's use in glioma. So the current standard is using MRI at all disease stages, and in particular, contrast enhancing volume on T1-weighted MRI typically shows disruption of the blood-brain barrier, which often indicates tumor proliferation. But when you get into the post-treatment setting, this can also be just due to treatment-related change. And so this makes it difficult for management, particularly in target optimization radiotherapy, accurate and timely identification of tumor recurrence, which is probably the biggest one. And then also its use in response assessment, such as the RAINO criteria, which still uses 2D measurements and is most often restricted to clinical trials. So FET-PET is showing promise in differentiating glioma and brain metastases, as well as its supplementary information for target volume delineation, as well as its most common indication within the clinic, or in clinics that use FET-PET, is that superior diagnosis of tumor recurrence. And now there are also PET-RANO response assessment criteria that have been released. So the FIG trial was a prospective, non-randomized, multi-center phase 2 trial, which is recruiting newly diagnosed glioblastoma patients. In particular, it's taking FET-PET images at three main time points, the first being at radiotherapy planning. That's at FET1. FET2 is your baseline imaging 4 weeks out post radiotherapy. And then FET3 is at suspected progression. And finally, this is what the delineation approach looks like. First, we place a spherical volume of interest around a suspected tumor volume with reference to the MRI, and then we do an assessment of the background uptake using this crescent-shaped volume of interest. We apply a 1.6 tumor to background ratio that's been established in the literature, and then remove any obvious non-tumor uptake, such as those that might be in the sinus. So how do we first understand FET-PET delineation variability? So I got a good understanding about this from nuclear medicine physician credentialing. In particular, I want you to sort of focus on the three benchmarking, the benchmarking exercises, which had 3 cases at that FET1 time point for tumor delineation, and 3 cases at that FET3 time point for response assessment and image interpretation. So this was quite a large credentialing study with 21 nuclear medicine physicians and analysis of 126 different contours, and a wide variety of prior clinical experience with FET-PET. So I was tasked with summarizing the central expert reviews of these contours, such as the number of violations and the resubmission rate, evaluating the variability in typical quantitative parameters, such as the tumor volume itself, as well as the mean tumor to background ratio and maximum tumor to background ratio. And then I wanted to dive a little bit deeper and do a very intricate pairwise contour overlap analysis and evaluate overlap between observers with a suite of metrics. So this summarizes the central review process and the results that came from that. So the initial pass rate was 78%, and then through resubmissions, all cases were then subsequently passed. Minor and major violations were noted for both FET1 and FET3 key assessment criteria. And then in conclusion for all this summary, the main thing we want to look at is the resubmissions and the reasons why clinicians were told to go back and redo their contours. And the most common causes were BTV contouring, background placement, but also time activity curve classification for the dynamic analysis, as well as the image interpretation of being quite really expert in that FET3 time point. So this shows just how variable some of these quantitative parameters can be, in particular for the biological tumor volume as assessed by the inter-class correlation coefficient. We saw a moderate to excellent agreement, but some cases had a lot wider variability than others. So it's a bit hard to see from this figure, but this is an example on the left. It was the most conformal cases. And in this image, you have 21 different contours sort of superimposed on top of each other just to show that conformality. So on the left, there's all the contours seem pretty close together, but on the right, this was the least conformal case, where you have this additional area of uptake as shown by the white arrow closer towards the midline, which some of the clinicians were including, whereas the experts weren't including that. And so you've got a bit more variability when you're looking at your different parameters. So to conclude, this was the largest multi-center credentialing activity that had been conducted in the world, and importantly increased clinician familiarity with FET-PET delineation interpretation and allowed us to identify common errors prior to the prospective phase of the clinical trial. And this was published in EJNMI, and then it shortly after received a positive editorial from a group in Jülich, Germany, which has the most experience with using FET-PET. Now onto radiation oncology credentialing, kind of a similar analysis to nuclear medicine physician credentialing, but we also had the clinicians do contouring of organs of risk as well as the usual clinic target volume delineation using MRI. But then what we did was incorporate a fixed BTV into that delineation process as well. And so this includes 19 ROs, a total of 57 contours, again, a wide amount of different prior experience with FET-PET. And so I just want to highlight that what I mean by saying when we're using a fixed BTV is that the BTV is constant between all of the ROs, so that the variability is just isolated to the RO contours and not sort of being brought forward by the nuclear medicine physician. And again, quite a similar analysis quantitatively. So the initial pass rate was 78%, and most resubmissions were just due to missing contours, which were all then subsequently obtained and then passed. You can see on the right the sort of overlap of all the different organs at risk contours, but in particular, when looking at some of the overlap of these organs at risk, the optic chiasm and optic nerves were low, which is pretty typical in the literature. These are pretty small. The optic nerves is a small tubular structure, and the optic chiasm is pretty small and hard to identify on an MRI. And these are all the target volume delineations. So what we found was that the hybrid GTV delineation was a bit more consistent between observers compared to the MR one, but you have to take into account that the BTV is fixed. You've got a part of the contour that's just consistent, so that kind of makes sense. But just use my mouse here. On the very right here, you can see here this is the MR plans and all the GTV, CTV, PTVs, and on the right is the MR plus FET. And so although the GTVs may be a bit more consistent, I kind of noticed that when we were expanding to the CTV and PTV, they were a little bit more varied. And so that's kind of shown here as well when looking at the dye similarity coefficient. You would expect a jump from your GTV, your MR-derived GTV and the hybrid GTV, showing an increase in performance, but you can see when you go to the CTV, suddenly there's like a drop in performance, which is interesting to see, and that's also shown in the mean absolute surface distance as well in some cases, which might require some further investigation. But I believe it's just potentially some ROs might not want to create such a large CTV or PTV. And they were given a little bit of flexibility for that expansion. In the protocol, it does state that 10 to 15 millimeters can be used, whereas for MR, you would just use a straight 15. Whether or not they chose to exercise that is not clear. And so to conclude for this was a good opportunity to provide participating ROs with experience in incorporating the BDP treatment planning. And one of the most important points is the demonstration of the feasibility of doing this collaborative delineation approach where you have to take a nuclear medicine division volume and then pass it on to radiation oncology as well. But one of the more interesting questions that may need to be answered as part of the FIG trial is how does the incorporation of a BTV impact some of the margin expansions incorporating areas that ROs are not sure of, such as hyperintensity on T2 and flare. So trying to decide if these intensities are vasogenic edema or actually infiltrating tumor. And so we're understanding how these delineations can vary, what the sources of variability are. So why don't we just try and automate some of these processes as well? So in 2023, a FET-PET automatic segmentation network was published, which was trained on 699 FET-PET scans, which is probably the biggest combination of PET scans you can probably find in the world. The disease cohort was predominantly glioma, but there was also brain metastases and other non-malignant uptake cases as well. It was made available for download from GitHub, and the senior co-author, Philip Lohman, reached out to myself to externally validate this network. And so we looked to see what data we had locally outside of the FIG trial, and the external validation cohort that I used was a data set that I used in my master's, which consisted of 24 glioblastoma patients from a previous prospective imaging study that was conducted here at Charles Gardner. This included a total of 52 PET images, and every patient had a scan around about 2 weeks prior to the radiotherapy. 9 of these patients had another retest scan 1 week after that, and then 20 patients had a post-radiotherapy scan. And just to start off with a simple analysis, we looked at the correlation of the volume that's segmented by a physician versus this volume that's segmented automatically, as well as looking at the quantitative parameters like the mean tumor to background ratio. And we see quite excellent correlation here. And this is in comparison to the below figure, which is from the 2023 study, where they've also found quite excellent correlation. But we all know that correlation doesn't always paint the entire picture. And so we did a little bit of a bland Altman analysis to see if there's any systematic bias in the differences between the physician and automated contours. And looking at volume and the solid line, which is our bias, it does show that the network tended to underestimate these segmentations compared to the physician, and that based on the quartile analysis, this underestimation became exacerbated as the volumes got larger. However, mean tumor to background ratio seemed to be quite stable. So a unique aspect of the data set is the test-retest data. And so something that hasn't really been looked at in the literature in this space is how consistent would a neural network be under test-retest conditions compared to a physician. And so we can look at that by measuring the repeatability coefficient, which is just the width of the dotted line, as you can see there. And in every case, no matter how you look at it, absolute relative for volume or mean tumor to background ratio, the automated measurements are more consistent than under test-retest conditions. Now, just looking at some example cases, what are some good segmentations, bad segmentations, and also some critical error cases? So the top left example of good segmentation, pretty conformal. On the bottom, the automatic segmentation network has only segmented quite a small portion of the tumor compared to the clinician, but I will sort of iterate that additional portion where the yellow arrow is was added in manually after the thresholding process by the clinician. On the right in figure A, there's a lesion that has been completely missed by the network, which is a small and low uptake lesion. In the middle, you have a lesion in the frontal lobe that's been largely ignored in favor of the network segmenting the transverse sinus. And then again, similar scenarios happen for a frontal lobe lesion. And what's interesting is that they've segmented both hemispheres of the transverse sinus as well. So clearly, this was the first external validation of a FET-PET automatic segmentation network. We found that the biology of tumor volume and mean tumor to background ratio were highly correlated, although the network did exhibit a bias towards volume underestimation and erroneously segmented areas of the transverse sinus. I've hypothesized that the differences in model performance compared to the original 2023 paper is potentially because the images that we used are reconstructed using a point spread function, whereas theirs isn't. I won't go into too much details about this paper, although it does highlight that lesion contrast is directly impacted by the application of the point spread function. The SUV in your lesion can increase, whereas the SUV in the background doesn't change too much. And so what the network has been trained on and is used to may then affect how it's looking at our images and then segmenting them. So we had a look at automating that segmentation process. Now, how do we further understand what we're segmenting and conducting a rich quantitative analysis of that? And that's where radiomics modeling comes in. So radiomics is the high throughput extraction of imaging features from medical images to characterize a region of interest. That figure in the middle there is just an example of doing this process on a lung CT. And I wanted to best understand what the best practices were for conducting a radiomics analysis and how to best create a workflow which works with limited data that we usually have. And so I had a look at what's called the radiomics quality score, which was proposed to improve study reproducibility and accelerate clinical translation. And it provides a set of criteria which touches on various areas of a radiomics pipeline and how to design your studies to a high quality. And this has become the de facto assessment tool used by systematic reviewers. So I was thinking that it might be a good idea to try and collate all of the applications of this radiomics quality score by these systematic reviewers. So this is basically a systematic review of other systematic reviews, which includes a total of 130 of them. And so we grabbed all the applications of those radiomics quality scores and attempted to correlate it with publication year, imaging modalities investigated by the papers that were evaluated, and the country as well, and then tried to summarize all these scores. So this is a bit of a busy slide, but the table in the middle is what you might see from a systematic review. They will include their papers, as you can see in red, and then they will apply the 16 criteria of the radiomics quality score in green, and then those will just be summated to provide the final score in blue. And so that's the score I was interested in. Just having a look at what is being reviewed and the areas of it's primarily the areas of oncology, in particular gastrointestinal cancer, which is again split up into a variety of different cancer types. And so in the end, we extracted about 3,258 of these quality scores, providing a mean RQS of 9.4, which is just above 25% of the maximum score. So most of these studies tend to be developmental and haven't really progressed to more of an advanced stage of development, at least according to the radiomics quality score. But we can see that there has been just an extremely significant increase in the score over time, as you can see from this box plot here. We had a look at imaging modality as well. CT and MRI tend to have roughly the same average quality scores, whereas PET is a little bit lower. And ultrasound is actually appears to be a bit higher, and those are significantly different, as you can see from the table. Why might that be the case, that there are some similarities and differences in quality scores? Perhaps it's just to do with how common and how easy it is to take some of these measurements. So CT is ionizing, but it's fast and common, whereas PET is ionizing, slow, and resource intensive as well. So there's less sort of imaging studies available. This is quite a large summary of the proportions of scores that are assigned to each of these criteria, as you can see on the left, as well as the average performance of each of these criteria, as well as observer variability in interpreting these scores. I've just highlighted in red some of the criteria that often isn't included in studies as well. And this potentially might be actually a sort of drawback of the RQS as well, as most studies aren't really trying to implement some of these criteria. So to conclude, the community is increasingly adhered to these quality scores over time, but progress is slow on things like phantom studies, test-through-test studies, external validation, prospective studies, cost-effective analysis, and open science, although there are recent communities such as the metric score, which appears to be trying to not really replace, but also supplement the RQS in a more conformal way. Although this entire analysis was very helpful for me to better understand the best way to radiomics quality, radiomics analysis, and also I just thought it would be important to develop guidelines which maybe useful to the community, and also guidelines that I just wish that I had at the start of my PhD. So I won't go into too much detail because we're running out of time, but these guidelines include looking at how to conduct an inter-observer variability study for looking at multiple segmentations, how to properly interpret discrimination statistics, and also the other side of the puzzle in terms of model performance, which is calibration statistics, basically how close are our predicted probabilities to reality in patients. Decision curve analysis to identify whether a model is clinically useful, and this involves actually going and doing clinical engagement and understanding what a useful clinical range for your model might be, and if that actually provides net benefit to patients or not. And if it's not providing net benefit, it doesn't matter if it's discriminative or has good calibration, it's just not going to be useful in the clinic. And then the development of a bit of a roadmap and trying to collate all this information together to try and bring the field of radiomics to a more prospective setting and trying to accelerate clinical translation as well. And so the main takeaway from my guidelines is that medical data is precious, and it is our responsibility as researchers to prioritize simple models with extensive clinical engagement during development and validation to make the most of the data we have. And that concludes my talk. Thank you for listening. Sorry, it's a lot to get through. Yeah.
Presented that at Trog or any of the other?
I attended Trog last year, but I had a poster, and it was the early days of that automatic segmentation algorithm. I was actually developing sort of my own to segment all the different components of the segmentation so that they could be edited manually if needed. But given that getting data from the actual trial itself was taking a little bit longer than expected, and then the group from Ulish had reached out to me, I thought it was just a perfect opportunity to do a bit of international collaboration and to conduct a study that's incredibly technical.
Has there been engagement with men to put the automation into?
Yeah. So I've sort of been actively involved in developing some of the workflows regards to it's more so quantitative analysis at this moment, but I know that there's definitely interest to sort of input and automatic segmentation in sort of the back end of them. Whether that's how that's going to look and how you're going to implement that so it's actually useful clinically, because as we've just seen, sometimes the segmentations could potentially, spit out stuff that's not very useful, and you might have to start from scratch or at least go back to a different step in that delineation approach. And ideally, you give that freedom to the clinician rather than just saying, here's the BTV, just trust us that it's okay. So I think that will actively develop in the future, and I'm involved in sort of the consultation for that process.
Early on, you just mentioned it can be used to differentiate between metastases. Again, so that mets don't have the same effect up to.
Yeah, I believe it often comes down to the maximum tumor background ratios. They have investigated just looking at different cutoffs and to maximize sort of or to provide a good AUC and sensitivity and specificity. I think at least in particular with the sort of grade 3, grade 4s, their sort of maximum uptake is much higher. And in particular, I think there's also differences in sort of the dynamic uptake as well over time. And so the metastases, I believe, don't have as much of an aggressive FET uptake compared to some of the more higher grade gliomas.
Treating primary neuromanagement is kind of a standard place for FET.
Understand. You can't get it.
Yeah.
I guess you want to insist on that. Just you don't have the gold standard should be the clinician conjuring or the vectors clinically. These patients can bring it on regardless.
I'd like to see a role for some sort of, I suppose, biological-based imaging to help us differentiate between necrosis, what's treatment effect, what's tumour, what's viable, what's not. That's, I think, at the moment, what I don't think is I think in terms of our treatments for glioblastomas, I think we put big enough margins on that it's going to be in there anyway. That's not all that we do. Your problems what happens after treatment.
So in terms of the initial culturing, the fit might just help to say, yes, it's within my GTV or C2, I'm not missing anything like that, but ultimately that would be a small initial goal.
Because we know that GBMs are grade 3s and 4s, they don't make nice small domains. They diffuse the infiltrating and even 1.5 centimetre CTV margin on. Still probably missing half the disease, which is why you see patients coming up with glioblastoma cerebral. It's not fine there. But it would be really useful to find some dynamic imaging that's accurate, reproducible, to help us work out what is treatment effect on the scans, what is viable disease scans. Management decisions.
I think that's what we're trying to find out, if that helps in that process.
I think potentially using FET imaging to guide dose escalation could be an interesting project as well. Not saying that it definitely works. It doesn't. There's no evidence that it does at this stage. But the interesting thing with all the dose escalation trials in GBM is they don't actually result in any more toxicity. And it's probably just similar to brain stereotactic treatment. You can prescribe a heterogeneous plan and not actually increase toxicity. So it's never been properly investigated using good quality imaging dose escalation. All the dose escalation trials in GBM have been complicated by the fact that the imaging wasn't great at actually identifying what you should dose escalate. There has been one using FET imaging, but it was a pretty small study. So I think depending on what the FIG trial shows, if they do show that it can assist with the initial target delineation, it might actually be more a question of shrinking margins and then escalating dose.
Yeah, I definitely agree.
Yeah, we will also get from the FIG trial a detailed analysis of patterns of failure, and whether it was within the field, at the edge of the field. Was it something that could have been better identified the edge of the field by using a FET PET, or and would that have prevented that failure? And then I think the other really interesting thing in gliomas is all the evidence, guidelines, and consensus statements that are now coming out about retreatment. And I think getting biologic imaging to guide retreatment for highly selected, very, very good performance status patients can enable them to live longer. And so I think FET imaging is definitely going to have a place. And I think it will be in part in designing the intervention.
Yeah.
Yeah.
I think you're sort of on the money there in terms of optimizing these target volumes, whereas you could potentially shrink them, but they're a little bit better guided by the BDV, particularly, as I mentioned, some of the infiltrating tumor components which aren't seen on sort of your usual T-on weighted imaging. And then once you're in post-treatment, using FET-PET as a response assessment marker to quickly pivot to some of those salvage therapies, as you mentioned.
Impressive amount of work. You've basically done 2 PhDs in one.
Oh, okay. Well, I can ask for 2, but I think they'll only give me 1. Thank you.